Okay, can you guys hear me?
Yes, we can hear you, Dr. Lin.
Okay. All right. Can you see the first slide over here?
Yes.
Okay. So Saisi, Nassim, and some of the other residents they told me that your right exam is coming up, and I scheduled with Saisi a few lectures over the next couple of weeks. What I'm going to do is I'm going to incorporate a bunch of the cases from the from like your prior right exams into the talk, and like I'll like when I show examples of different pathology, I'll pull up examples from like your right exam showing that, just to kind of just do it that way. So I'm going to start. I'm going to start now because I'm a couple of minutes behind, and there's a lot of slides to show. Pretty much. So like this is what I'm going to be talking about today. It's like there's many different obvious diseases that you can get congenitally that can affect your brain, different congenital brain malformations. What I'm going to talk about today is going to be the major ones that I think you might see in a test or maybe in like in clinical practice, which are divided kind of up into these three broad categories that you're seeing over here. So I'm going to kind of go really quickly through this like embryology stuff. I'm not sure if it's really relevant for like your exam or unless you're like a peds neuro fellow, that kind of thing. So in terms of like the development of like your CNS, like you have this neural plate that comes from ectoderm. The edges of that plate kind of kind of come together and like a neural groove forms in the center. So your two folds kind of come together, and then when that happens, that forms a neural tube. And it's kind of like it starts in the middle, and then like a zipper kind of like closes at each end, top and bottom. So if you have problems with the upper part of the neural tube kind of closing appropriately, that can give you Chiari malformations and Cephaloceles and Agenesis. If the bottom part doesn't close properly, then you get things like spinal dysraphism. So this is our first case that I want to show you guys. Saisi, tell me what you see on here.
Look like low-lying cerebellum with questionable syrinx in the upper cervical cord.
Perfect. So low-lying, pointy or peg-shaped cerebellar tonsils that go all the way down, at least to the to like the posterior arch of the C1 ring. There's an area of low T1 signal that kind of matches CSF within the upper cervical cord, so that's a syrinx. So what do you call this then? That constellation of findings with the low-lying peg-shaped tonsils.
Chiari I Malformation.
Exactly, perfect. So this is an example of a Chiari type 1 malformation with a syrinx. This is an example from your right exam, kind of showing the same thing. They're not pointy, but the cerebellar tonsils kind of go down pretty low. If on an axial image, say you're reading a head CT, and like there's too much soft tissue in the foramen magnum, and the tonsils go down to level of the at least they go down to a tip, that's too low. And this is an example of a syrinx, this kind of fluid signal, well-defined structure in the upper cord, kind of like the example I just showed you. So this is more of the same thing. So low-lying kind of pointed tonsils that go several millimeters below the foramen magnum. Depending on which book you read, the cutoff it might be different, but in general, if it goes below 5 or 6 millimeters below the foramen magnum, that's a Chiari. That's criteria for a Chiari malformation, especially if it's pointy or peg-shaped. This is an example of a syrinx, bright on T2, following fluid signal, and dark on T1. In general, a syrinx, like you really want it when they're sizable, you really want them to have dark T1 signal matching CSF, just to make sure you're not dealing with just edema from, say, like an intramedullary lesion. And this is just CSF flow within the syrinx, pulsatile. So normally your tonsils go up and down with like a piston-like motion with CSF flow that kind of moves with systole and diastole. When you have a Chiari malformation, you get abnormal CSF flow dynamic, and that's how you get the syrinx. Some more examples of the same thing, low-lying tonsils with a syrinx. Again, if it's a sizable syrinx, then to really confirm it's definitely a syrinx, look at the T1, make sure it's very dark. If the T1's not as dark as fluid, then you got to think, could this just be edema from an intramedullary lesion, or say like transverse myelitis or something like that? All right, more of the same thing, low-lying tonsils. This is just another person with a Chiari malformation and a syrinx just lower down. Okay, how many types of Chiari malformations are there? When I was first taught in radiology, like 15, 20 years ago, they used to say there was like 4. Then they cut that down to like 3. Now, depending on which literature you read, there's a few more subtypes. There's a Chiari 0, there's a Chiari 1.5, depending on like if there's like kinking of like their cervicomedullary junction. I think for now, most review books just have 3 types of Chiari malformations. Okay, let me see who else is here so I can call on other people. Ben, what do you see on here? Like, so this is another Chiari malformation. It's a Chiari II. Can you tell me like one or two additional things that you see on here that make it a Chiari II? There's
The
one
corpus,
specific thing on here that makes it a Chiari II.
the corpus callosum is not fully developed, and there's like a large posterior fossa area.
Okay. What do you think of? So this is your cerebellum. You have a small posterior fossa with the cerebellum squashed into it, and then low-lying tonsils over here. Fourth ventricle is gone. So this is your brainstem, midbrain, pons, medulla. What do you think of the tectum?
It's abnormally shaped. It looks kind of pointy. It looks abnormal.
Yeah, it's beaked.
Be...
It's beaked actually. So that's a classic finding with Chiari 2 and 3. You have 4 colliculi, 2 superior and 2 inferior colliculi. They fuse when you have a Chiari 2 or 3 malformation, and you get what's called tectal beaking, which looks pointy in both the axial and the sagittal planes. So there's a number of different things that you'll see with Chiari 2s and 3s, but the big things you want to look for intracranially are going to be low-lying tonsils, the tectal beaking, the high-riding appearance of the cerebellum, and in addition to that, they often get dysgenesis of their corpus callosum. They often get an enlarged mass intermedia, tightly packed gyri, which the Latin name for that's going to be stenogyria. And this is the same thing on in the axial plane. So tectal beaking, you can see in both the sagittal and the axial plane, and it's from fusion of the colliculi, which some people say is heart-shaped. Okay. Ben, there's an additional finding on here with this patient has a Chiari 2. Can you tell me what that is? There's tectal beaking. That's a pretty obvious thing in the center over here, but there's something else on here that's not normal. Can you see what it is?
Lack of lateral ventricles, or is that too low?
Forget that for now. I think maybe it's just the cut.
Okay.
Okay. What structures in the midline? What dural structures in the midline that goes from the front to the back?
The sagittal falx.
Yeah, exactly. Do you see how the gyri are kind of crossing over?
So it's not fully developed and it's sort of ragged looking?
Yeah, so actually, if you have a Chiari 2 or 3, they can get fenestration of their falx, and what you might see on an axial image is that the gyri cross the midline, they interdigitate, so that's kind of like a classic finding with that too. You're not always going to see a Chiari in the sagittal plane with low-lying tonsils. You might have an axial image only to look at. So the main features here that go with the Chiari 2 or 3 are going to be the tectal beaking and the interdigitated gyri. This is just another example of the same thing. And that's that heart-shaped tectum that we just talked about. So since we're still talking about the same topic, Ben, what spinal abnormality do you see virtually in 100% of people that have Chiari 2? These are the
I don't think it's a myelomeningocele.
Perfect. Yeah, almost 100% of people that have Chiari 2 have a myelomeningocele, which you're seeing on this example over here. If you look, it's kind of hard to see the distal cord. It might be like over here, but if you look, there's a defect in the posterior elements that has meninges and CSF kind of herniating through with fat kind of overlying it. And this might be the same thing over here, but it's not as good of an example. And there's like massive hydrocephalus. So just know that myelomeningoceles are something you see in virtually 100% of Chiari 2 malformations. All right. So which of the following is not associated with Chiari 2 malformations? So you definitely have tonsil ectopia, you definitely have a myelomeningocele, and they definitely get tectal beaking from fusion of the colliculi. So the best answer here is actually going to be lipomyelomeningocele. Let's see. So this is actually an example of a lipomyelomeningocele from your right exam. If you look on here, you can see like this is the thecal sac coming down, and if you look over here, there's a defect in the posterior elements with kind of fat going between both sides. And same thing over here. You can see all this abnormal fat and maybe some like nerve roots kind of coming down over here. So this is an example of a lipomyelomeningocele, just so that you know. Since we're talking about abnormal fat in the spinal canal, this is another thing that that's been shown in the past on your right exam. So this is a normal Sag T1. If you look on here, if you look at the epidural fat posteriorly, it's these diamond-shaped kind of quantized individual units that you're seeing like that. That's what normal posterior epidural fat looks like. When you have when you start having it where it's like more abundant like this, where it stops being kind of like individualized, that's what epidural lipomatosis looks like in the sagittal plane, and on the axial plane, it kind of makes the thecal sac squash, kind of like with this trifold appearance. This is another example of the same thing. So again, normal epidural fat in this thing over here is quantized, individual diamond-like units. This is an example from one of your old right exam tests where the epidural fat, instead of being kind of individualized, is a big sheath that's continuous, and you have that trifold squashing of the thecal sac that you're seeing over here. So getting back to Chiari malformations, this is something that you can see if you do plain films of the skull in people that have Chiari 2 and 3 malformations and other things that can give you spinal dysraphism. You can get these thumb-like lucencies in the inner table of their skull. And the Latin name for that is going to be what's called Luckenschadel, and this typically resolves after a few months after birth. This is more stuff that you might see with a Chiari 2. So these are OB ultrasounds. Ben, this is a normal OB ultrasound over here of like the baby's skull being nice and kind of like ovoid and not deformed. Do you see this skull over here? There's a name for that where you see kind of like this indentation of like the skull anteriorly. Do you know what that is, Ben?
I don't know.
It's named after a fruit. It's called the lemon sign. And that's something that that you might see if you have a Chiari 2 malformation that you'll see in utero. This is because the skull is pretty soft. You'll see this, I think, during the first 24 weeks or so, but if you image them later on, the skull gets more developed and it kind of disappears. You see this in different things that cause spinal dysraphism, including Chiari 2. This is another example, something you might see named after a fruit with Chiari 2 malformations. So if you look over here, like this is your cerebellum that you're seeing over here. It's normally supposed to be kind of like straight and like shaped like a dumbbell. And if you look over here, it's shaped like a banana. This is the banana sign. It's something else they talk about you might see with Chiari 2 malformations and other things that, and other congenital brain malformations. But this also disappears after 24 weeks. So it's something you want to see earlier on. So we talked about Chiari 1, we talked about Chiari 2. This is an example of a Chiari 3. You'll see all the stuff you see with Chiari 2 that we just talked about with like the tetal beaking and things like that. But instead of a myelomeningocele with Chiari 2, you get this, this high cervical occipital encephalocele. And this is another example of the same thing. Chiari 3, low-lying tonsils, occipital encephalocele with this like cerebellar parenchyma plus CSF and dura and like other soft tissue overlying it. That's kind of like Homer Simpson. All right, so to summarize, Chiari 1, low-lying tonsils, more than 5 millimeters below the foramen magnum with or without a syrinx, which I showed you a couple of examples of from my cases and plus your right exam. Chiari 2, we talked about, has like virtually 100% association with myelomeningocele, has a lot of different brain findings, but the ones you want to really like remember are going to be the tetal beaking, the towering cerebellum, and that fenestration of the falx where the gyri kind of interdigitate. Remember, myelomeningocele is what you'll see with Chiari 2, not a lipomyelomeningocele. And I showed you some examples from your right exam of what a lipomyelomeningocele will look like. And then Chiari 3 is all the stuff you'll see with the Chiari 2, but instead of this, they get an encephalocele. All right, so we finished that. I'm going to keep going. I'm going to try, I have to go kind of quickly because there's a lot of stuff to talk about. Plus I have some right exam slides to go through as well. So the next thing I'll talk about is encephaloceles. So to kind of make this simple, this is a, if you kind of look at this as a normal brain, everything is where it should be in terms of like the brain parenchyma, CSF, and dura. Nothing's herniating outward into the wrong space. This is a, if you look at this sandwich, all the ingredients are kind of like where they're supposed to be. It's nice and neat. This is a sloppy sandwich. There's all this stuff herniating out into the wrong spaces, cheese, vegetables, whatever. This is an encephalocele with all kinds of stuff. The brain ingredients are hurting out into the wrong spot. So you name cephaloceles based on which part of the brain, or if you will, brain ingredient that's kind of coming out. If it's just CSF and dura, it's a meningocele. If it's brain parenchyma 2, then it's going to be an encephalocele. I'm just going to kind of go through this quickly. So these are just some examples from some cases that I showed you so far already. So if it's brain parenchyma plus CSF and dura, it's a meningoencephalocele. If it's just CSF and dura only, that's a meningocele, which you see over here. And let's see, are there any peds neuro people here? Let me just see.
Yes.
Who is that?
We have one new in theater.
Hey, okay. So I'm going to go through some questions and I'm going to show you some cases here. So do you know what type of cephalocele is more common in Caucasians, say like Europeans or North Americans?
No idea.
It's actually occipital. Apparently that's supposed to be an important fact, at least for radiologists. So this is the most common type of encephalocele overall. Occipital is again more common in people of I guess like Caucasian background. And when you have one brain malformation, you should look to see if there's others, because they very commonly go they're commonly multiple. So if you see one thing wrong, keep looking for other ones. People that have cephaloceles may also have Dandy-Walker malformations, Chiari malformations, issues with their corpus callosum, and migration anomalies, and which can give you seizures. So your goal when looking at this is to kind of identify where the encephalocele is kind of hurting through, and say what structures are going through it. Is it just CSF and meninges? Is there brain parenchyma too, and their relationship to the vessels? So why don't take a look at this case and tell me what you see that's not normal on here.
You can see a CSF kind of going through. Looks like the occipital encephalocele.
Right, right. So is there brain parenchyma going through it, or cerebellum?
It kind of just looks so, I guess possibly. It looks almost all like CSF, but I guess so.
Yeah, I mean, there's not really any parenchyma going through there. So it's a cephalocele specifically. It would probably be a meningocele. There's CSF and just dura. What else is wrong with this patient? Which there's something else that's wrong on the posterior fossa here.
We don't have all the developmental sample, I'm sorry.
You can't really see like most of the cerebellum. You're looking at it from this sagittal view. It looks like the cerebellum is quite little.
Right. There's a specific part of the cerebellum that's small though. Like which part of it? In the midline with a V.
The vermis. I said the vermis.
Okay. Yeah, so if you look here, the vermis, like it should be a pretty well-defined structure with multiple lobes that kind of wrap all the way around. If you look at this case, the cerebellar vermis is extremely underdeveloped. It's very small. There's a huge cystic space in the posterior fossa that communicates with the fourth ventricle in association with this encephalocele. So what do you call that when you have a very small vermis with? Go ahead.
Dandy-Walker malformation?
Exactly. I mean, this was definitely shown a couple times in the past on your right exam, which I have examples of, I think, later on. So just know that. So this is an encephalocele, and again, when you have one brain malformation, they often happen with other ones too. What else is wrong with this patient? Look at the lateral ventricles in the third ventricle.
They're quite dilated.
Right. So what is that?
Hydrocephalus?
Yeah, exactly. So I'm just like showing that like the complete thing for this would be an encephalocele, Dandy-Walker, plus there's hydrocephalus. All right, so this is an example from your prior right exam. A very small vermis, posterior fossa cyst kind of going into like the fourth ventricle. And normally your tentorium should kind of go down at like a 45-degree angle. When you have Dandy-Walker malformations, it enlarges your posterior fossa, it elevates the tentorium. And there's this term people talk about called torcular lambdoid inversion. Your straight sinus is over here. It should kind of go down to a 45-degree angle, and your torcular should be around here. When you have anything that makes your posterior fossa enlarged, including a Dandy-Walker malformation, it kind of elevates your torcula above your lambdoid suture. So that's what that term is from. This is another case from your right exam. So small vermis, posterior fossa cyst, and again, your tentorium should go down like this. This is markedly elevated. So enlarged posterior fossa with a cyst, small vermis, cystic space communicates with the fourth ventricle. This is an example of a Dandy-Walker malformation. Let's see. Bueno, so just take this one too. Take a look at this case and tell me what you see.
So here you can see, the cystic dilatation, or like you have the like the CSF and everything coming out. But there's more to it as well.
Right.
I just don't know if this is like a fatty material or what is this.
So there's all this extra fat kind of overlying in the scalp. There's this big thing containing CSF and dura. So there's an encephalocele, there's brain parenchyma going into there a little bit. So it's going to be like a meningoencephalocele. And it's like in the occipital region. So an occipital meningoencephalocele. So that's done. What else is wrong with this patient? Look at their tectum and look at their tonsils.
Well, the tonsils is a bit low lying, and
How about the tectum? Is it normal or not normal?
yeah, no, it's abnormal.
Right. So do you remember what I told you that's called when you have what type of Chiari
That's
happens with encephaloceles? Is it 1, 2, or 3?
Chiari 3, sorry. That's
Good.
Chiari.
Good. Perfect.
Can you see it?
Okay. So what type of cephalocele is more common in Southeast Asians? So we just talked about the occipital. That's more of something you might see with people with a Caucasian background. Frontoethmoidal encephalocele that involve your midface and your anterior skull base. That's less common of an encephalocele, but you see that more with Southeast Asians they talk about. So these are just some examples of that. You can see there's a defect in the anterocranial fossa floor with brain parenchyma herniating out. So this is one example of that. This is another case over here that has mostly CSF and like meninges coming out. Another example over here with like the basal frontal lobes going through the floor of the anterocranial fossa into the nasal cavity. I mean, the big importance of this is that you don't want to you don't want to miss this. Think this is sinus disease. A surgeon operates and gives them a CSF leak. All right, so that's done. Who else here is part of Peds Neurology?
Theodore.
Hey. So take a look at this case. It's a fetal MRI. So take a look and tell me what you see.
Honestly, I don't know what I'm looking at.
Okay. All right. So it's actually a twin gestation. Like you see these two frog-looking things that are actually like babies. Look at this one over here. So this is the like the fetus's head. This is their trunk over here. Probably umbilical stuff over here. That's their orbit with their globe. Do you see a cranium or no cranium?
I guess I don't see it.
Right, and there's all this weird like kind of like stuff kind of going above there. So what do you call that? Let's say you do like a fetal MRI like after 10 weeks and you could see no cranium and no normal brain tissue above the orbits. What's that called? It begins with an A.
Anencephaly?
Exactly. So this is an example of what's called anencephaly. It's another issue with dorsal induction and neural tube defect. It's from lack of closure of like the rostral neuropore. So again, your neural tube closes in the middle and then goes like a zipper top and bottom. If the top isn't closed properly, then you'll get things that we talked about just now, Chiari's, encephaloceles, and in a severe case, anencephaly. All right, just some basic background information about it. Apparently, it's a pretty common birth defect. And things you might look for are going to be markedly elevated AFP. And again, if you have one of these malformations, you should look for other ones too, because it's very common for them to happen in conjunction with each other. So this is an ultrasound just showing, again, like if you look over here, these are their orbits. There's no brain parenchyma or cranium above the orbits on this image. They say it looks kind of like a frog. Which, I mean, that's what the other images kind of looked like. So again, above the orbits, no brain parenchyma. And more images of the same thing. If you look, this is their orbits. Above that, there's no brain parenchyma, but there's no cranium. If you do see tissue, it's not brain parenchyma. It's something that's termed angiomatous stroma. All right, so we covered these couple of ones. I'm going to keep going now and talk about some more of these. There's definitely these shown on your prior RED exams, which I'll show you slides about. Okay, Theodora, I want you to take this one too.
Okay, so
All right.
this is very obvious, like holoprosencephaly.
Okay.
So see the formation of the two cerebral hemispheres. They haven't completely separated. And you have an enlarged single ventricle, which I'm for, but I can't remember it right now.
Okay.
And you also like don't see the normal like layering of the cortex either.
Sure. Okay. So when you take these cases, like what I would do is it'll help you by time, say the type of study in the plane. So this is a coronal CT scan. And you're right. If you look on here, there's this monoventricle, this enlarged monoventricle that you're seeing in the midline over here. You don't see an interhemispheric fissure or kind of like a like a falx in between. And what are these two structures over here that are fused, part of the diencephalon?
The thalamus.
Perfect. Yeah. So this is an example of holoprosencephaly, probably Alobar Holoprosencephaly because there's no separation at all. Okay. So this is due to failure of differentiation and cleavage, which happens around the 5th week. It's a forebrain thing. It's not really a posterior fossa thing. And it can be associated with different chromosomal abnormalities like Edwards or Patau's, or I reverse that actually, I think. And very commonly when you have these cleavage anomalies, like you also have abnormalities involved in the midline of the face, like cleft lip, pallid issues, and the hypertelorism. So there's 3 different kinds of these that in terms of in varying degrees of severity. This is the worst when it's alobar, and this is like the least worst when it's more lobar. What they all have in common is that they're all going to have an aspum septum pellucidum. So if you're looking at a head CT or an MRI in a patient and the septum pellucidum is missing, that's your clue that you might have some kind of major congenital brain malformation underlying in that patient. Okay, so this is just an example of that. So if you look at their brain, it's kind of like one pancake-shaped structure without cleavage in the center. You'll have a monoventricle that goes backwards as a dorsal cyst. Same patient, if you go inferiorly, the thalami are fused. So that's the major findings for alobar. This pancake appearance where the brain's kind of one single thing, a monoventricle infusion of the thalami without a falx or like a interhemispheric fissure really between the two structures. Theodora, do you know what it's called when your ACAs come together, only one of them kind of goes up like this?
It's not a fetal ACA. That's for the
No, the fetal PCA is where it comes directly off your ICA without a P1. So when you have one single ACA going up in the midline, there's a name for that because of an A. An azygous ACA. That's something that you might see with an associate. I mean, normal people can have this, but you can also see this with people that have midline congenital brain malformations like Alobar Holoprosencephaly. Some more of the same thing, pancake-shaped forebrain without cleavage, this big monoventricle with a dorsal cyst. Same thing over here, more examples of the same thing. Pancake forebrain, no separation, monoventricle with a dorsal cyst. And that's the case that you took in the beginning. So this is an example from your right exam kind of showing this. If you look, there's kind of this weird looking like single, like kind of funny looking ventricle in like the midline, and there's fused thalami. So this would be an example of holoprosencephaly. I could see some separation kind of anteriorly over here. So this is probably not going to be alobar. It'll be more of a lobar or semilobar type. So again, this is the money shot with the fusion of the thalami with this funny looking ventricle. This is an example of holoprosencephaly. So as I was saying before, people that have holoprosencephaly can also get facial issues in the midline. So this is a really severe example with cyclopia. This person has a cleft lip and they have a hypotelorism, kind of really closely spaced eye sockets. And people that have holoprosencephaly can also get this thing called a proboscis, this kind of thing that looks almost like a nose, but it's really high, kind of coming out from like the front of the person's I guess glabella, named after the proboscis monkey. So that's alobar that has no separation. When you start to get some cleavage posteriorly, then you're getting into what's called semilobar holoprosencephaly. So if you look over here, like the patient has a kind of fusion of the brain anteriorly. There's some separation of the brain posterior, like you're seeing over here, and there's some persistence still, some fusion of the thalami. Another example of that as well. So the front of the brain is fused. The back of the brain is a little bit separated. The thalami are fused, and that's the ventricle not fully separated into two structures. Okay. And this is lobar holoprosencephaly. When you have more kind of cleavage of the brain, which again starts from back and goes so towards like the front, when you have that where it's really like much more differentiated like this over here, that would be more of the lobar type of holoprosencephaly where you have much more separation. So if you look, the occipital and parietal lobes are well separated. You can kind of see well separated lateral ventricles over here. You don't really have fusion of the thalami, or if they are, it's more separate than you would see with the other examples. And just for you to know, so your corpus callosum, when you have a congenital issue with it where part of it doesn't form properly, it's usually the back part that's missing. The only exception to that rule that I know of is when you have holoprosencephaly, you can get it where the middle of the corpus callosum is missing and the front and back are there as a congenital variant. Okay, let's see. Matt Block.
Hello.
Okay,
Okay.
so this is definitely something that they've showed on your right exam, and I'll show an example of that. Like this is my example, but I have one also that was from your right exam. So take a look at this and tell me what's missing or what's not normal here.
So we are looking at a coronal CT. I don't see a
It's not a CT, it's something different.
Oh shoot.
MRI.
Yeah, what sequence is it? The scalp fat is bright and the white matter is bright. So what sequence is this?
That's a T1.
Perfect. Okay. So now you've identified the sequence in the plane. Now tell me what you see that's not normal or missing on here.
I don't see a septum lucidum.
Perfect. Good. So this is your pituitary. Your stalk would be over here. What's right above that over here?
The corpus, the genuine of the corpus callosum.
Corpus callosum is here. Like that's this structure. What supracellular structure is going to be above the infundibulum over here?
The optic chiasm.
Perfect. Yeah. So missing septum pellucum, that's never normal. If you see that, that's a sign of underlying, like a major underlying brain issue. And their optic nerves and organ and chiasm are small. Do you know what the name of this entity is?
No, I don't.
Okay. It's called Septo-Optic Dysplasia, and the eponym for this is called Demorsia's disease. So it's thought to be one of the least severe forms of holoprosencephaly on that spectrum, and like what the major findings are going to be like missing septum pellucum and small optic pathways. A lot of these patients will also have seizures. The reason why is because they often get congenital gray matter issues, including schizencephaly. So this is another example. So this is the same case, and if you look on here, the septum pellucum is missing. If you're looking at a case and that's missing, that should clue you into this entity or some other thing, some other issue along the spectrum of holoprosencephaly. So this is a case from your right exam. If you look on here, there's no septum pellucidum. I mean, they're showing like their orbits over here. I'm guessing they're trying to show that the optic nerves are small. So this is probably an example of septo-optic dysplasia from your right exam. So I talked about different types of holoprosencephaly just to show you the spectrum again, just to summarize. Alobar is going to be one pancake-shaped forebrain fused thalami with a monoventricle like you're seeing over here. Semilobar is when you start to see some cleavage posteriorly, but the thalami and frontal lobes are still fused. Lobar is when you have like more cleavage going anteriorly, but there could still be some fusion of the frontal lobes and the thalami. And then the least severe form on that spectrum is going to be septo-optic dysplasia, where there's no septum pellucidum and the optic nerves are small. Let's see. Wonu?
Yes.
Okay. Take a look at this case and tell me what you see on here that's not normal. So what's missing on here?
So basically, you're just seeing a giant, what do you call it, CSF space.
Okay.
Is a CT. You can't really see much of a brain anteriorly.
Mm-hmm.
There's a little bit posteriorly.
Yeah, you can see the posterior circulation structures there. So do you know the name of what the name of that entity is, where you have kind of congenital like absence of your I guess of your forebrain because of like an in utero insult? It begins with an H.
Hydranencephaly? Oh,
Hydranencephaly, yeah. So this is a coronal image. This is an axial image showing you the same thing. There's no kind of like there's no cerebral hemispheres. You can see kind of the posterior circulation stuff is preserved though. So is this Alobar Holoprosencephaly? The answer is no, because like you can see some brain parenchyma here, and like this patient has like a falx, so that's wrong. Is this hydrocephalus? No, because even in the worst case of hydrocephalus, you'll still see like a cortical mantle over here. Best answer here is what you just said. This is an example of what's called hydranencephaly. This is a pretty severe brain malformation. It's due to an in-utero insult, which can be vascular or infectious, that kind of involves the anterior circulation. And because of that, you don't really develop your cerebral hemispheres. The posterior circulation stuff will be there, but like you won't see cerebral hemispheres typically. All right. Theodora?
Yes.
Okay. I'm calling you on you guys more than the others because this is pediatric stuff that I want to make sure that you guys know. So take a look at this case and tell me what's missing, and like, well, tell me the type of scan, the planes, and then tell me what's positive on here, what's abnormal.
So the first one is a sagittal T1.
Good. Okay. And the middle and last one?
And then the middle one is a coronal T1. And then
Okay.
the last one is an axial T2.
Perfect. Good. Okay. And now what's wrong with this patient?
So a few things wrong. One is like you see very like enlarged posterior ventricles.
Okay.
Look kind of like colpocephaly.
Good.
And
Good.
I see like, corpus callosum, really.
Right. It should be here, but in this case, you don't really see the corpus callosum at all. You can see kind of the sulci and gyri radiating down to the roof of the third ventricle, which is kind of high riding. If you look at the curl image over here, the interhemispheric fissure goes all the way down and communicates with the third ventricle. And the frontal horns have this funny like steer horn appearance like you're seeing over here. And if you look, actually, the white matter tracts that were meant to cross over are kind of bumping into each side over here of like the medial edge of the brain. Do you know what the name of those tracts are? Like it begins with a P that are meant to cross over, but they don't? Probe spondles. Probe spondles. Okay, so this is an example of agenesis of the corpus callosum. So how does the corpus callosum typically form? I think classically they talk about how it forms from front to back. Genu, splenium, genu, body, isthmus, and then splenium, and the rostrum kind of forms last. So overall front to back, and then this structure over here. So when you have dysgenesis, it's usually going to be where like the back part's missing. The one exception that I told you about that rule is going to be if you have like say like a holoprosencephaly type of case, and if you have that, the front and the back might be there, but not the middle. So if you look over here, this is an example of dysgenesis. So again, classically, when you have dysgenesis, the back of the corpus callosum will be missing because it's the part that kind of forms last. In general, acquired things are going to be that's what I would think of when I see the front and the back kind of present, but the middle's missing, unless you have say like holoprosencephaly. Okay, so just to repeat, if you have one brain malformation, it's very common to have other brain malformations too along with it. So if you have agenesis of your corpus callosum, it's very common for that to be associated with other things. Commonly a midline cyst or lipoma, but also heterotopia and other seizure-causing things, Dandy Walker and Chiari malformations. So the answer for this is actually all the above. So this is your case. So no corpus callosum, high riding third ventricle with a gyri and sulci kind of radiating directly to the roof, with an absent or inverted cingulate gyrus. This is an axial. These are axial images kind of showing the same thing. So if you look on here, there's a parallel orientation of the lateral ventricles. Your splenium of your corpus callosum kind of cinches together your posterior horns of your lateral ventricles normally. So if you don't have that, it'll kind of balloon out like you're seeing over here. They say this kind of, radiologists at least say this has a race car appearance, but I don't really see the race car myself. So this is a normal kind of like brain MRI over here. The caudate heads indent the frontal horns, give them a shape. The splenium cinches the occipital horns, gives them a shape. So it looks kind of like a corset. These are kind of like big occipital horns called colpocephaly, which kind of has this junk in the trunk appearance. More examples of the same thing. So the interhemispheric fissure goes all the way down. There's no corpus callosum, they communicate. The frontal horns on a coronal image are going to have this steer horn appearance or Viking helmet appearance. And the white matter tracts are meant to cross over. They're kind of bulging on each side, are called Probst bundles. All right, I'm just going to kind of go through this quickly. Let's see, so normal over here, that's septum pellucidum. If you look at this case over here, this is the corpus callosum here. If you look at over here, it's missing. The interhemispheric fissure goes all the way down to the third ventricle. The two frontal horns are upturning, kind of like a Viking helmet or like steer horn. And this is Matt's case, midline coronal image. There's no septum pellucidum. The optic chiasm is small. This is an example of a Septo-Optic Dysplasia or Morse's disease. All right, I'm going kind of quick because I have a lot to cover and I want to kind of show you as many like right exam cases as I can. So I'm going to keep going for like another 15 minutes or so. So intracranial lipomas, that's another congenital brain. That's another thing that you could see that's a congenital finding in your brain. So you get this from like abnormal kind of involution of this thing called the meninx primitiva. It's a mesodermal structure that helps form your subarachnoid space. Because of that, when you get lipomas, they're going to be in your subarachnoid space. And you can get them in, they're classically midline, but you can get them in different locations. So like most common is going to be along the falx, which you see all the time on head CTs. And then where else can you get them? You can get them like along the corpus callosum, within the quadrigeminal plate cistern, and then in the IAC is like another place that you can see them as well. So these are some examples of pericallosal lipomas. Big picture wise, if they're small and kind of like, especially if they're kind of curvilinear along the falx, like you're seeing over here along the back of the corpus callosum, that's typically a benign finding. If you see a really large one, like you're seeing over here, that's associated with the anterior part of the corpus callosum, that's going to be like, that's often going to have other brain malformations associated with it. So the curvilinear one is usually, or little, if it's just small isolated droplets of fat that are in the falx, interhemispheric fissure, or in other locations or along the back of the corpus callosum, that's typically benign, curvilinear. This the large one, what's called tuberonodular, that's more anterior, like you're seeing over here, that has a high association with other brain malformations, such as agenesis of the corpus callosum. These are congenital. They often have nerves and vessels coursing through them, so you typically don't want to resect these unless it's causing some kind of major issue for the patient. So this is the tuberonodular type that I was telling you about. So it's going to be more anteriorly located, and this one has a high association with other brain malformations, including agenesis of the corpus callosum. This is the curvilinear kind, which is more likely to be benign. Another example of like small ones that are typically going to be isolated benign. So this one's in the quadrigeminal plate cistern, and this one over here is going to be within the CP angle cistern. Theodora, what can you do to prove that this is fat if it's like an MR? Or anybody for that matter can answer.
Stir imaging or T1 FATSAT?
Perfect. Yeah, I mean, like FATSAT, T1 or T2, like any of those, but like so T1 FATSAT or STIR, or you could just look at their head CT to see if it's fat attenuation. I'm just going to keep going now. All right, so this is an example of it from your right exam. If you look over here, SICE, if there's this really bright T1 signal structure kind of intradural behind the dorsal aspect of the cord that you're seeing. It kind of is similar to the fat that's over here, kind of within the subcutaneous tissues. Different things are bright on T1. Fat's a big one. What else? So proteinaceous things can be bright on T1. Blood products, specifically methemoglobin is bright on T1. Mets from something like melanoma can also be bright on T1 as well. So how do you prove this is fat? So if you look at this case, this is actually a T2 FATSAT or a STIR. This is suppressing out. So this is a spinal intradural lipoma. All right, so we talked about these. We talked about Holoprosencephaly, Septo-Optic Dysplasia, the corpus callosum. I'm going to talk about this, and then after that, I'm going to kind of move on to these migration anomalies. There's a lot of these actually that I keep seeing on your right exam, so I'll kind of go through those cases. All right, so for cerebellar malformations, I'm going to talk about these three major ones. Okay, so I kind of showed this already, just so that you, this has definitely showed up in the past in your right exam for the past couple of years. Wonu took this case before, so like I'll just kind of go through it quickly. If you look at this, there's a very small cerebellar vermis. The tentorium should normally go down at a 45-degree angle or so, and the torcle is over here. If you look, there's a huge posterior fossa cyst. It's elevating the tentorium. The torcle is not in the normal place, and that cyst communicates with the fourth ventricle. This is an example of a Dandy-Walker malformation. They may also have aqueductal stenosis, and if you look, the other ventricles are enlarged too, and there's hydrocephalus. So if you see one thing, keep looking for other things as well. If you look at this, so this is just kind of showing the typical stuff I would look for. So 3 major things for a Dandy-Walker malformation: huge posterior fossa with torculolambdoid inversion, a very small absent or hypoplastic vermis, and then that cyst that you're seeing back here communicates with the fourth ventricle. Okay, so just another example of the same thing. Small vermis and large posterior fossa, cyst that communicates with the fourth ventricle. These are all features of Dandy-Walker malformations, and this is the case I showed you before from your right exam from a year or two ago. And the same thing, another case from your right exam for like 1 or 2 years ago. Small vermis, big posterior fossa with a cyst that communicates with the fourth ventricle. There's a spectrum for these Dandy-Walker abnormalities. If you have the 3 things that we just talked about, that's a Dandy-Walker malformation. If it's less severe, where there's like a more formation of the vermis and like not really a huge posterior fossa, that's called a Dandy-Walker variant. And if you have an enlarged cisterna magna behind the inferior to your vermis, that's a megacisterna magna. So I'll go over that. So if more of the vermises form but the bottom part's deficient and you don't have a huge posterior fossa, but you still have a cyst back here, that's what's called more of a Dandy-Walker variant. And if you have a situation like this, where you have a normally fully formed vermis, but there's like this cystic space kind of behind and inferior to the vermis, if that cystic space has septations and vessels in it, it's a cisterna magna. If you have a cystic space with no architecture, that's an arachnoid cyst. So if you look on here, cystic space with septations, this is a megacisterna magna. If you look at this case over here, there's this big cystic space kind of behind the cerebellum, but there's no vessels inside of it. This is actually an example of an arachnoid cyst. So if you see septations and vessels, megacisterna magna. If you don't see septations and vessels, it's more likely to be what's called an arachnoid cyst. Let's see, Saisi, can you hear me?
Yes, I can.
Okay. What do arachnoid cysts look like on diffusion? Do they restrict?
Arachnoids, I think they shouldn't restrict. Oh.
Right. Arachnoid cysts look like CSF on every single pulse sequence. Let's say it does restrict. What would you think of instead of an arachnoid cyst? What cyst that classically happens at the cerebellopontine angle cistern restricts? Begins with an E? Epidermoid. So this is an arachnoid cyst that's not restricting. Okay, so I'm just going to kind of run through this quickly. Saisi, do you know, this is kind of a classic appearance where you're seeing this is the junction of the midbrain and the pons. These superior cerebellar peduncles are really elongated, and it kind of has a molar tooth shape. Do you know what this is a classic example of?
I remember molar tooth. I'm not sure.
All right. Anybody know what this is? It begins with a J. It's a French name.
Joubert.
Perfect. Yeah. I mean, it has a very classic appearance. So if you can get easy points on this, I would just commit this to memory. So that's obviously a molar tooth or premolar, and it looks kind of like the way the brainstem looks over here with really long superior cerebellar peduncles. So this is an example of Joubert syndrome. So this is normal, like midbrain pons junction with like the normal looking superior cerebellar peduncles. This is that molar tooth shape that you see with Joubert's. The fourth ventricle can have differing appearances with this. This kind of has like an ace of spades appearance, and this is kind of like a bat wing look. All right, and let's see. Wonu?
I'm not sure what I'm looking at.
Can you hear me?
Yes.
Okay, so take a look at this case. Like, what's wrong with this person's cerebellum? Like, you see how the white matter goes straight across? Like, it's like one big cerebellum, like going straight across like that?
Yes.
Okay, there's what's in the middle? What belongs in the middle over here?
Middle over the vermis.
Yeah, the vermis is not there. You have the white matter kind of crossing over. So it's like holoprosencephaly involving your cerebellum. What's that called? It begins with an R.
Oh, is that the
synapses?
Yeah, so exactly. This is normal. Two cerebellar hemispheres with a vermis in the middle. This is an example of rhombencephalosynapsis, really long word. Just fusion of like the cerebellar hemispheres with without like development of the vermis in the midline. So again, you're seeing the white matter tract going straight over without a well-developed vermis, and kind of like a keyhole shape of the fourth ventricle. This is a very old picture of my daughter from like a long time ago. So we talked about these. I'm going to go through this quick because I definitely have several like red exam questions from here that I just want to go over with you. Your brain develops in a few different stages, and like the cortex specifically, the gray matter develops in a few different stages in terms of proliferation and kind of like creation of the cells and like multiplication of them. Then they migrate out from like the center of the brain, kind of like where the caudothalamic groove is, the germinal matrix, out towards the surface along these things called radial glial fibers. So proliferation, migration outward towards the cortex, and then they organize into the different layers, 6 layers. If you have any kind of insult to the brain that kind of affects the migrating cells and development of the cortex, then you get gray matter migration anomalies or cortical development anomalies, which are kind of all like hamartomas. And because you have abnormal development of the cortex, you get seizures from them. So let's see. So again, like they start off over here centrally and they kind of like radiate outwards. If something like prevents that happening normally, then you get these different diseases that I'll show you slides of. So let's see. Paula?
Yes.
Okay. So take a look at this this case. This is a coronal T2. This is an axial T1. There's thick, broad gyri that you're seeing over here that are not well developed, and a huge ventricle on the same side. And this kind of confirms that on the axial image. Do you know what this is called?
Lissencephaly. But it's only on one side.
Yeah, exactly. So it's not really, Lissencephaly is more of like a bilateral diffuse process. This is just one side has thick, broad gyri and a huge ventricle. It begins with an H.
I'm not sure.
Okay, so this is an example of what's called hemimegaloencephaly. Think about that when you have a huge ventricle with thick gyri on the same side. All right, so more examples of that. Thick, broad gyri with a huge ventricle. I would think of hemimegaloencephaly. All right, so since you're here, Paula, I want you to take this case and tell me what you see. This is another cortical development malformation.
Yeah, so we have axial T1, flare, and then coronal, that's T2. So on the left frontal, we have some sort of cortical dysplasia, but there's abnormal gray matter.
Yeah, I think you've already pretty much said the answer. If you look at the left frontal lobe, the cortex is really, really thick. I mean, the gyral pattern is not normal over here, and the axial image kind of confirms that. There's an abnormality. It follows gray matter on every single pulse sequence, and in this case, it's too thick, actually. So this is an example of what's called focal cortical dysplasia, where you get localized thickening of your cortex, which can be like, it can be localized, unlike lissencephaly or pachygyria. And what you'll see again is going to be thickening of the cortex, and it might look fuzzy with loss of gray white differentiation. The big thing you'd be worried about here in differentiating from would be maybe a glioma, which might have mass effect, and if you do MR perfusion, it'll have elevated perfusion inside of it. So this is another example of the same thing. If you look over here, this is kind of some thickened cortex. If you look over here, this is a normal gyral pattern on the left. If you look at the right side, there's a thickened gyrus over here with loss of gray white differentiation and funny margins, fuzzy looking margins actually. So this is an example of cortical dysplasia. The major differential for this case would be a glioma, which again would show mass effect, and you could do advanced imaging for perfusion and spectroscopy to tell this from say like a tumor. And another example of the same thing. So this is like perisylvian cortical dysplasia. If you compare sides, the insular cortex and the margins of the frontal and temporal opercula are too thick. So now we'll talk about migration. So this is an example. So if you look at this kid's brain, it's like too smooth. So this is an example of Lissencephaly. So there's a spectrum between like Agenesis, Lissencephaly, and like Pachygyria, that kind of thing, which all those things kind of give you a smooth brain. So this is an example of Lissencephaly that you're seeing over here, and this is just what a gross pathologic specimen showing that there's no gyri or sulci. Yes.
Oh, really? Is that why? It's like just like dropping knowledge.
Another example of kind of the same thing where you're seeing kind of this kind of smooth-looking brain. This case actually has a second abnormal finding where there's like extra layer of cortex over here. So this is Lissencephaly, but the patient also has heterotopia. And this is from your right exam. I believe this is an example of Lissencephaly. There's no kind of like gyri or sulci besides the sylvian fissure that you're seeing over here. There's no sulcation. This is also from your right exam. I'm not sure what the correct answer is, but when I look at their brain, like I don't see a good normal gyral pattern or sulcation. So this might be an example of Lissencephaly from your test. So just showing you kind of like the spectrum over here. So this is Lissencephaly, and then as you go further out, it becomes more like, I guess, Agenesis or Pachygyria with these thick gyri that don't have a lot of sulci. This is another example of Pachygyria, where you have these really thick gyri that you're seeing without a lot of sulcation. And this is something that has definitely showed up on your right exam a couple of times. Sergio, can you hear me?
Yes, I can hear you.
Okay. So I'm going to kind of finish up in the next 2-3 minutes because I'm going over my time, but I just want to make sure that you see this. So take a look at this case and tell me what you see.
So we had a MRI. On the left, there's a T1 sequence. On the right, we had a T2 sequence and shell cuts. And I think like we were seeing some like abnormalities around the ventricles, kind of like a rivotine kind of scene. It smells like, it looks like white matter, I think. No, sorry.
So, all right. So the first one is a flare, and this is a T2.
Oh, okay.
If you look at the lateral ventricles, there's nodules. And if you look at them, are they the same or are they different from the cortex? Is this nodule the same signal as the cortex? And is this nodule kind of similar to the cortex?
It's similar to the cortex.
Okay, so what do you think that is then? If you have a person with seizures and these nodules that are the same as gray matter in every single pulse sequence?
Tuberous sclerosis?
Nope, it's not that. That's the differential, but it's definitely not that. Anyone want to help him? What is this? Let's see.
Ventricular nodular heterotopia.
Perfect. Yeah. So this definitely has showed up a couple times on your past couple of right exams. So the major thing you're looking for here is going to be gray, like these nodules that look like gray matter that are going to be in the wrong location, and they have to look like gray matter in every single pulse sequence to really call it heterotopia. So if you look over here, there's these kind of nodules that are kind of following the same signal as like the cortex, and they should not enhance and they don't calcify. So there's one over here that's the same as the cortex. There's one over here that's the same as the cortex, and there's like a bunch of them over here that don't enhance and they're the same as the cortex. So this is from your right exam, some examples. So if you look on here, this is T1, this is the dark cortex, the nodules are the same signal. This is a kernel T2. Cortex is this signal intensity, and the gray matter over here, these like heterotopias kind of match that. Another example from your right exam, you have all these like kind of like little nodules that follow the kind of same signal as the cortex. This is an example of heterotopia again. and this is like a third example from another one of your right exams. There's multiple nodules that you're seeing kind of around the ventricles. They're exactly the same signal as like the overlying gray matter cortex. This is heterotopia. If they were calcified and they enhanced, then I would think, like you're saying, Sergio, of tuberous sclerosis. If they're not calcified, if they don't enhance and they look like gray matter in all pulse sequences, then it's heterotopia and not nodules from tuberous sclerosis. So this is an example of what you might see with tuberous sclerosis. You get nodules along the margins of your ventricles, but they often calcify, they often enhance, and they don't follow gray matter signal. This is band heterotopia. It's just gray matter in the wrong location, but instead of being nodular, it's kind of like a band like you're seeing over here. And this has an association with Lissencephaly. Just going to keep going. So this is the last, second to last entity I'm going to be talking about. Srinivas. Wonu, can you hear me? Wonu?
Yes.
Okay, so just quickly, a patient with seizure, what's wrong with the brain over here?
So you have a schizencephaly, basically?
All right, so coronal, axial, coronal again.
Yes.
Tell me why it's schizencephaly, and there's different kinds. Tell me like which specific kind of schizencephaly this is.
So you can have the open or closed
Right,
lip.
okay.
If it's like continuous with the ventricle, then it's open.
So all of them are going to be a cleft that goes from the cortex to the ventricle, like you're seeing over here. If you have it where the edges of the cleft are closed like or opposed like this, that's a closed lip schizencephaly. And there's one feature on there here that helps you confirm it's definitely like a schizencephaly and not just some other kind of cleft. Do you know what that is? What's the cleft lined by?
Oh, it's piloependymal cells.
But what's this over here? It's cortex. Like it has to be lined by gray matter or it's not schizencephaly, in other words. So if you look on this example, there's gray matter lining it, there's gray matter lining this, and there's gray matter lining this over here. So 3 examples of schizencephaly, closed lip, and if you're not sure if it's really a cleft, what you might see is this kind of dimple of like the ventricle going outward. Okay, so this is from your right exam. So this is a bilateral schizencephaly case, and so is this one. The left side one is kind of like open lip. The right side one is kind of closed lip, and your clue is going to be that kind of dimple coming out on each side. So this is open lipped, a cleft going from the cortex to the ventricle, lined by gray matter. And this is another example on the other side showing a cleft lined by gray matter going from the cortex to the ventricle. If you're not sure, I mean, I would look for that dimple coming out. And Theodora, what's missing in the midline over here?
The corpus callosum.
Septum pellucidum.
Oh, septum pellucidum, sorry.
Yeah, just know that, like, I mean, when you see a missing septum pellucidum, it's a harbinger for like other stuff. And people that have Septo-Optic Dysplasia very commonly have seizures because they often have schizencephaly. Just more examples of the same thing. More examples, open-lipped. So lined by gray matter, huge cleft. Another example of the same thing, lined by gray matter, huge cleft. You can't really call schizencephaly unless you see that gray matter lining. And this person also has a missing septum pellucidum. I'm just going to skip this, actually. So, I mean, polymicrogyria, I mean, you're going to see, like, classically, if you compare size, just too many kind of, like, nodular undulating gyri, like you're seeing. It can be localized, and very commonly, it's perisylvian. Let's see. So this is the last thing I'm going to show. It's like it's a congenital thing that you can get in your brain that can give you a specific kind of seizures. So Theodora, 10-year-old, laughing spells and precocious puberty. This is from like one of your prior right exams. Tell me what you see over here. Like, tell me the sequence and tell me what this is, what you see over here, and what the location of it is.
So this is a sagittal. Is it T1? Yeah, that's T1. And it's like in the area of the hypothalamus. It's kind of, I guess, heterogeneous, I would say.
Right. There's kind of like a mass in the region of the hypothalamus. You should normally see like pituitary infundibulum. You should see like your chiasm. The tuberous syndrome should just be like a line over here along the bottom of the third ventricle. Instead, there's just weird kind of pedunculated mass like sitting over here where the tuberous syndrome lives. So let's say you see this, you gave contrast and it does not enhance. What would that spell out for you? What do you think this is? with this history.
Is it a hypothalamic hamartoma?
Perfect. Yeah, hypothalamic hamartoma or hamartoma of the tuberous cinereum. What's the medical term for laughing spells?
Elastic seizures.
Right, right. And these patients also get progressive puberty because the hamartoma affects, I guess, like different hormones, including LH. All right, so that's pretty much it. I think your brains are full. I went through like a lot of stuff today. You guys know how to get me. My number is 5103, or you can email me if you have any questions. I'm scheduled to give like 1 or 2 more lectures. What I'm going to try to do is like kind of the same thing. I'll talk about a high-yield topic, and I'll try to put in whatever I can in terms of like whatever's recent for your writing exams to help you guys out. All right, with that, I'll just end the lecture. Good luck, guys.
Thank you. Thanks a lot, Dr.